All right. Good morning, everybody. Thanks for being here today. Dominic was not able to attend today, so me and Jorge will be doing our darndest to
Yeah,
facilitate here. And yeah, thanks y'all for being here.
great. Good morning, everyone. Thank you for being here. My name is Jorge Gonzalez, the Medical Psilocybin Program Manager, and we have other folks here from the Department of Health joining us. But Ian is the chair, and Ian, take it away.
So good morning, everyone. My name is Ian Dunn. I'm the chair of the Patient Qualification and Safety Committee. I want to welcome you guys all here, anyone who decided to join. We really appreciate your input. And just as a quick reminder of what committees are, they're a way to facilitate community input into the board. That way we combine the minds of New Mexicans across the state to make the best possible program for New Mexicans. On today's agenda, we are going to have our tier 4 not appropriate at this time considerations, also referred to as exclusion criteria. And if time permits, we will go over psychiatric and neurological considerations. So we will begin with brief introductions if you would like to participate in today's meeting. Just give a brief introduction. You can raise your hand on who you are, what is your area of expertise. Maybe it's medical, maybe it's social work, maybe it's, just working with disadvantaged persons, and whatever it is, we would love to hear from you. We want to know, are you from New Mexico or elsewhere? You are allowed to participate in the committee meeting if you are not from New Mexico. We just want to know if you are or not. And then do you have any other affiliations? Are you with the American Nurses Association, American Association of Physicians, anything like that? But I will go ahead and turn it over for introductions.
All right. And to introduce yourself over mic, if you'd like to do that, there's a mic icon in Teams up at the top right portion of the screen. And if you see that, you just have to click that to select that. Oh, but first, for raising your hand, sorry, that would be the first thing. Jorge's got the slide up there, and it's just a hand icon. You raise that, and then I will allow your mic privileges after that. I also see in the chat, Catherine Sanchez is introducing herself. Catherine Sanchez, Bureau Chief Workers, Compensation Administration, Medical Cost Containment Bureau. Thank you.
Perfect. Since I don't see any other hands at this time, we can go ahead and go forward with just discussing the exclusion criteria as they're presented. That way we can have more discussion. I know some people get a little bit shy introducing themselves, so we will just go ahead and look straight at what we are going to be discussing today.
Okay. Ian, which tier 4, you want the tier 4 document open?
Yes.
Okay. Bring that up for you. All right.
All right, perfect. So these conditions are tier 4, not appropriate at this time. So using the clinical support framework that we adopted at the last meeting, the following criteria are recommended for placement in tier 4, which states that they're not appropriate for participation at this time. So there are currently a couple of situations which would warrant exclusion, individuals under the age of 18. At the last meeting, we decided that there's not currently enough clinical evidence to support the use of psilocybin in those under the age of 18. I do want to remind, because I did see some public comments in regards to this, that if a patient was going through end of life, qualified for the program under end of life, they actually are outside of our clinical support tier. We deferred that entirely to the end of life committee. So this would only be for the standard non-end of life care patients, couldn't be under the age of 18. Second, we have pregnancy. Unknown risks to fetal tissues. We don't want to cause any harm to a developing fetus. And 3, breastfeeding, unless the patient and provider implement and document a plan to pump and discard breast milk for at least 24 hours following administration. So that's just standard protocol, just making sure that we're not taking, the baby on a trip. And the next section is medications. So for all disqualifying medications, I don't want the provider just to say, no, you take this, you're out, done. So I included language that said, the provider shall document a discussion with the patient regarding whether the benefits of tapering and attempting psilocybin treatment outweigh the clinical risks. So the current most risky ones are use of lithium in the past 30 days. This increases seizure threshold and can be a risk to patients. The use of MAOIs in the past 30 days is a huge increased risk of serotonin toxicity. And then we have active intoxication from alcohol or non-medicinal substances at the time of evaluation, or recent stimulant use, including cocaine or amphetamines, within the past 5 days due to increased cardiovascular risk. Again, pretty straightforward. Cocaine and amphetamines both increase your heart rate and can have increased heart blood pressure. Sorry. So we don't want to add a psilocybin, which can also increase heart rate and blood pressure, because that would put them at strained cardiovascular risk. The next section is going to be stabilization before treatment. So these are not full-on disqualifying. We're not saying, this ever happens, you're out. But we do want to make sure that we further assess them. We want to make sure we stabilize them and that they're in the right state of mind for psilocybin treatment. So this would include things like an active psychotic episode, clinically significant uncontrolled hypertension, uncontrolled diabetes mellitus, uncontrolled seizure disorder, or current suicidal or homicidal ideation with intent, plan, or inability to maintain safety. All pretty standard. Diabetes mellitus can come with electrolyte imbalances, and that can cause that can be exacerbated by psilocybin. So we want to avoid that. We definitely don't want to induce a seizure, and we definitely don't want to put someone in a situation where they may be a risk to themselves or others. So I believe those are all pretty justified. If you could scroll down for me, Jorge. Perfect. And then these are the hard line conditions. So these are contraindications to participation in psilocybin services and are not eligible for treatment regardless of enhanced clinical support or specialist consultation under tier 2 or 3. Reassessment may occur for medical conditions that have demonstrably resolved and for which documentation supports sustained clinical stability. Enduring psychiatric diagnoses associated with an elevated risk of psychosis or mania are considered exclusionary. So if someone has bipolar, but they've been stable for a long time, they would be able to get that reviewed. But if someone does have like an active bipolar that is coming with mania and all sorts of other things, then we might want to exclude them at this time until we can get demonstrable resolved activity for that disorder. This also, adding this resolved documentation or resolved language allows for, let's say a patient goes to one medical provider, gets diagnosed with bipolar, and they actually had ADHD. Well, if the second provider is able to mark that initial condition as resolved, this would allow them to still participate in the program without being overly exclusive. So these conditions are schizophrenia spectrum disorders, so schizophrenia, schizoaffective disorder, and schizophreniform disorder. It is a history of persistent or recurrent psychotic disorder, including psychosis precipitated by serotonergic psychedelic exposure. That is really big words to say. If you develop psychosis due to taking a psychedelic medication, then we should definitely not be giving you more. We just want to make sure that you're safe in the right state of mind. And if this is going to be a problem for you, we definitely don't want to give you something that's going to make you worse. I included a history of bipolar 1 disorder, and I think this might be one of the more contentious areas. There is emerging evidence that bipolar 2 may be benefited by use of psychedelics. So I didn't want to write it as a hardline exclusion at this time, but I would understand if you guys wanted to. Bipolar 2 definitely doesn't have the same level of evidence that the rest of the conditions do. So if you wanted to do it now and put bipolar 2, we could. just recognize that it may become a qualifying condition in the future. So if someone had, let's say, PTSD and bipolar 2, they may be able to benefit from psychedelic treatment, whereas someone with bipolar 1 generally would be made worse. And in terms of a history of borderline personality disorder, this was very simple, very straightforward. It can come with rapid mood swings and rapid cycling, which can cause problems if we're trying to get them into an integration therapy, have them stable during administration, and allow them a true healing process. Obviously, for cardiovascular issues, severe congestive heart failure, active structural heart disease, valvular disease, cardiac hypertrophy, and clinically significant arrhythmias, as well as cerebrovascular disease and pulmonary disease requiring supplemental oxygen, active coronary artery disease, including history of myocardial infarction. Those are all caused because psychedelics can increase your blood pressure and strain on your cardiovascular system. So we definitely don't want to make those situations worse. Some other less medical, they still are medical, but less specific diagnoses are a known allergy to psilocybin-containing mushrooms. Obviously, not everyone's going to know right away if they have an allergy to psilocybin-containing mushrooms, but if we do find out, probably shouldn't give them more. And an active inability to provide informed consent. I think this is very important. A patient needs to know what they are getting themselves into if they're going to undergo this treatment. So if they are unable to understand what the drug is and provide that informed consent, I don't believe this is the treatment for them. But that is all of the conditions that I have currently listed. So if anyone has some other conditions that they think should be added, I would let you raise your hand now.
Again, to raise your hand, in Teams, there's a icon at the top that says raise with a hand icon. If you're able to do that, and then I can enable your mic privileges from there.
I also did want to note, I did totally forget to say, I was moving things between, separating out the situations from the medications, from the conditions, but from what needs to be stabilized. And I guess while moving things around, I totally forgot to include borderline personality disorder in the version that I sent out. I do want to note that it is included in this version. And then once again, I'll turn it over. Is there any conditions we think need to be added? All right, I'm seeing no hands. Let me check the chat.
Don't see any hands raised or anything in the chat so far.
All right. So does anyone have any conditions that they think we need to strike?
You have a quiet group this morning, Ian.
I do. Well, if we do not have any additions or striking that we need to do, we can go ahead and have a vote on the adoption of this exclusion criteria. If you can pull up the hand slide for me.
Yes. Okay. Getting there.
Oh, hold up. We got and then we got a couple of hands. Was that for votes or for speaking? Just want to make sure I let everyone go. Voting. Okay, cool. All right. Then we will go ahead and raise your hand now at this time if you are in support of the not appropriate at this time document that I had just read out.
Okay, so far I see 4 hands.
All right, with 4 in affirmation, do we have any negation? At this time, please lower your hands. All right, and then please raise your hand if you are in negation.
See no hands, Ian.
Perfect. 4 yes, 0 no. This recommendation passes. So we can go ahead and move on to our psychiatric and neurological considerations.
Okay.
Also, just real quick, for everybody who voted, if you also could, if you wouldn't mind just leaving a brief just introduction to yourself in the chat as well, that would be helpful.
Thank you, Johnny. All right.
All right, so I will now at this time, so current psychiatric conditions that we did not just vote on include delusional disorders, impaired reality testing, dissociative disorders, delusional disorder, dementia or moderate to severe cognitive impairment, history of traumatic brain injury with residual deficits, and we just did on those. So does anyone have any psychiatric conditions that you feel we missed in that original one? And I see a comment. That was an introduction. All right, and then so I will go ahead and go through these in order. I will open up discussion on delusional disorders. So which of the 4 tiers, and I'm going to give you a little reminder. So tier 1 is standard support, what most patients will go through. Tier 2 is enhanced clinical support. It is basically just creating a risk mitigation plan for the patient, but not requiring too much extra from them. Tier 3 is where it gets a little bit more barrier-esque. That's where there is 2 specialists that need to sign off. And then tier 4 is what we just voted on, not appropriate at this time. So for delusional disorders, what are we feeling? And I see Anne's hand is up.
All right, and I have enabled your mic. You can unmute whenever you're ready. Again, to do that, there's the mic icon up at the top right of the Teams window. If you are having issues as well, you might want to check there's a little arrow with a drop down that has speaker and microphone settings. If you want to check that the correct microphone is selected as well.
Sorry about that. I had to log back out.
Oh, no worries. Thanks.
I guess I was just wondering, is it a history of delusional disorders and impaired reality testing, or is it current active delusional disorders?
So I imagined it as a history of delusional disorder.
Okay.
So with a history of delusional disorder, I'll go ahead and write that in. What category would you put it in? I'm kind of leaning 3 or 2, maybe 4, if we're being really strict. But I did want to hear y'all's thoughts.
Well, I mean, I'll be really transparent about this. I mean, I don't live in Albuquerque and I don't live in Santa Fe, and the likelihood of being able to have a medical provider with me during a session to do this really is highly unlikely. And also, I just think my patient population would not be able to afford that. So a lot of these conditions would be conditions I wouldn't even consider working with, because probably I'm going to end up working alone. Which is not to say I want to make rules for the rest of the state based on my personal circumstances, but just to kind of offer some transparent feedback. I work in Colorado, and, I would really not be comfortable even working with somebody with bipolar 2 on my own. So, I would be really open to other people's thoughts, but just recognizing the geographic differences in our state and also sort of access to resources. It's just something to kind of consider that these would be tier 4 for my personal circumstances.
Perfect. Thank you so much for sharing. And then I see James.
All right, James, I have enabled your mic.
Morning, Ian and group. My thoughts on this, Ian, are definitely, with our risk mitigation strategy, right? This fits right into that category. Schizophrenia is one of those very history it fits right in here for psychiatric conditions and disorders. I think for the delusional disorder, definitely we need to have schizophrenia. I'm really torn because they definitely still need help, but this has to be a category 3 to me. And I'm with Ann. We need to look at resources and with our provider availability, and especially with a specialist, very limited. And so we need to really look at, but I still think it needs to fit into a 3, Ian, because it's a very serious condition that can go very south on you if you don't have the stuff ready. Even if you have it ready, it can still be unpredictable. So to me, schizophrenia, of course, I didn't know if that was that also that. I know we talked about the bipolar spectrum disorders before. I think some borderline personality fits in here as well. Of course, the active hallucinations, mania, hypermania, any active delusions, paranoia would also be somebody that would be schizophrenic. So I like the history of schizophrenia versus active on this one, because most people that are schizophrenic are active in and out. So I like more of the history thought, but that's just my piece on where it fits in a category 3 versus just excluding them completely. Thank you.
Yeah, so where I had put history of schizophrenia spectrum disorders in the first document that we worked on, it was listed as a exclusion unless they had documentation to show that it had demonstrably resolved. I am definitely one that says, like, just because you had episodes or things in your youth doesn't mean that that's going to carry on for you your whole life. It also doesn't mean it's not going to carry on for you for your whole life. So I definitely have considered schizophrenia as, like, we can maybe do it. I am very uncomfortable given the genetic predisposition to schizophrenia. Typically what we see in practice is schizophrenia can be almost not avoided, but if we don't have a trigger for it, it can remain dormant for a long time. And so my fear with schizophrenia specifically was that it would be the activating cause for those hallucinations and for, their other symptoms that they're experiencing. And I didn't want to leech onto that. So I had originally put it in tier 4. But for delusional disorders, are you saying for tier 3 or 4?
Tier 3. I like a good tier 3 approach, Ian, on this one for the delusional disorders, just to see if we can give them an opportunity. Like you said, maybe mentally, chemically, they've changed, maybe not. But it does allow at least a reassessment, right? So that's the kind of thought on this one is a reassessment. I like that idea. I like your approach on it.
Yeah, okay, perfect. That sounds good to me. I would concur with a tier 3 as well. Does anyone have any? I would put, and then Ellen in the chat said, I agree to put history of delusional disorders in the same place as history of schizophrenia spectrum, since it is in the schizophrenia spectrum, reassessment tier 3. Okay, so we will put delusional disorders in tier 3. It also looks like postpartum psychosis or delusional disorder might be an example where it would be appropriate to be in tier 3. That was from Ann Metz. So I definitely would support that. I think that delusions and psychosis both are very variable. And I think that's why in trauma-informed speech, we typically use like whatever word they use to describe the feelings that they felt plus experience. But I do believe that this psychedelics have an increased risk of psychosis, especially if they're already vulnerable to things like that. So I would concur with a tier 3. What about history of impaired reality testing? And then Ellen.
All right, I have enabled your mic, Ellen.
Thanks, and thanks everyone. I guess for the, last time we had our meeting, I had mentioned too about kind of thinking about what we're talking about from an assessment perspective, because I think this is an important piece, is what are we defining as a history of impaired reality testing? Because a lot of times we will look at something like even poor insight as, impaired reality testing. So, I just think that that's, for me personally, I think it's a little too vague to even mention.
Okay, so we have current discussion on striking the impaired reality testing. I would be okay with that only on the grounds that we already said that it would be irresponsible to allow someone who had, was it inability to provide informed consent? So I think that would also fall under there to be protected. But if we don't like the vagueness of this language, we could definitely strike it. What does anyone else think? I do appreciate your comment. All right, and then James.
Your mic is enabled.
Thank you, everyone. And Ian, and Ann, with the Freudian thoughts on that, my thought is that currently we could strike it. I just think we're still covered. I just don't know if we need to exclude that, especially with the cause of that and the basis of it and what we're actually looking at with diagnosing that. I would just strike it at this time. That's my thought too, with Ann.
Perfect. I went ahead and striked it if there are no other comments. All right. And then the next one we have is dissociative disorders, DID, dissociative amnesia, and then other dissociative disorders, depersonalization and derealization disorder as well. Any comments on dissociative disorders?
Looks like there's a comment in the chat. Anne wrote, nice improvement.
And then Anne also has her hand raised. Your mic is enabled.
I'm sort of curious if there's any, is there anything in the literature about dissociative disorders benefiting from this? I'm just kind of trying to imagine the REMS that they're going to have with any FDA approval, and trying to imagine a situation in which somebody with DID would be eligible. It just seems really unlikely. And I just, for the integrity of our program and for its continuance in the future, just being far out of line with what is happening across the nation, feels like it could be sort of problematic. But obviously there might be literature that comes down the road that says that it could be a helpful treatment. It just sort of seems like it's a really significant clinical risk for anyone to take. I might be inclined to put it in tier 4.
I actually wouldn't disagree with that at all. I think tier 4 is probably the best place. The reason why I included it is because severe PTSD can have dissociative symptoms that can often be either miscategorized or jointly categorized as a dissociative disorder. And I don't think we should be taking someone out of their current headspace if they have an inability to stay in their current headspace. Not that that's a bad thing, just that I don't want to create undue risk to the facilitator and to any other patients that may be around them. So I would concur with tier 4, but I'd love to hear what Ellen has to say.
Sure.
Well, thanks, Ian. I was going to say something very similar in the sense of when we see in PTSD dissociative, it really is a trauma response, and it's really it's not the problem, it's a solution for them a lot of times for patients. So I want to be clear about maybe, is this something again that's been in the past? Is this a current, maybe that needs to be redefined, because that was something that was with some of the other things that we've talked about, where I don't want to just, again, I was also worried about if someone was just like categorized as a delusional disorder or put on top of a PTSD, where that really has been the solution for them to disassociate, and that, honestly, at the end of the day, we would hope that any kind of trauma processing, especially done with a psychedelic, could be actually helpful for that. So that would be my argument, is just to not have it there at all, but maybe looking at if there was a history of that again and a reassessment. Thanks.
Okay. And then James.
Ian, also to include with this dissociative disorders with the DID and the DRDP, normally we also include the depressionization and derealization disorder. That falls underneath that dissociative disorders. I just didn't know if we wanted to include that and then move it to 4. That's my thought. Thank you.
Yeah, so I would consider DPDR to be with dissociative identity disorder and dissociative amnesia, and would concur with it being in tier 4. My problem kind of is to concur with Ellen in that sometimes providers, instead of entering a diagnosis for what the diagnosis is actually supposed to be for, they enter it to explain symptoms. So for instance, if someone is having PTSD but with severe dissociation, they might enter a code of a diagnosis to remind them when they next see the patient that, hey, this person has a lot of dissociation symptoms, check in on that kind of thing. And not necessarily because they are actually have a true dissociative disorder. So I would be okay with striking or moving it to tier 4, but I do, given there's a little bit of a mixed bag, if there's any other comments on that, would be appreciated. All right. For now, as a placeholder, we will just keep it in tier 4. And then, so for neurological considerations, I considered dementia or moderate to severe cognitive impairment. However, I think that this is already covered on our inability to provide informed consent. So I would also be we could either strike it or we could keep it in tier 4, or I suppose put it wherever you guys feel is best. But I will open comments for dementia or moderate to severe cognitive impairment.
Cool. And just in the chat, Ann Metz says building policy around providers who do a lousy job of diagnosing is problematic. And then Ellen Schimmel says, well, and the DSM isn't always helpful in differentiating, so there is a lot of clinical leeway.
Especially like something I've seen a lot in the medical cannabis space is marking a patient as cannabis dependent, which doesn't mean that they have a use disorder. It doesn't mean that they are, actively struggling with addiction. It means they use cannabis and they depend on it to relieve their symptoms. So it's just a note to the provider themselves to say, hey, they use cannabis, watch out for things like serotonin syndrome and others. But it's not necessarily bad that they're entering things like that. It's just another way of note taking on our patients. And then Ellen had a comment.
Thanks. I agree with what you just said too, Ian. And I was just going to say I hate to always be a stickler for semantics, but when we talk about residual deficits, I worked with a lot of patients with TBI, and I guess we're talking about what level of residual cognitive deficits, because there's a big spectrum.
Yeah. I actually would agree to just strike that entirely
Okay,
because we got the informed consent part. That's all that mattered to me in regards to the TBI with residual deficits was, are they able to give informed consent? If they are, great. All right. So I will go ahead and strike dementia and traumatic brain injury. So I want to ask, is there any other psychiatric conditions you feel like I'm missing that we need to add that have kind of slipped through the cracks? I'm not perfect. I will occasionally forget a certain mental condition, psychiatric condition. And yeah, if there's any others that you feel that I am missing at this time. Yes.
In the chat, we've got from James Brown for dissociative disorders. Can we add depersonalization, derealization disorder?
Yes, we can. I have just added it to the list. And then something I had heard in the written comments was about HPPD. Do we have any thoughts on that? James?
Ian and group, I have actually a lot of thoughts on HPPD. It is something that's very rare, but it's something that's very serious. It is something that we need to have an idea that it will occur. And when it does occur, what's our action plan? We need a plan around this as a state, as a group, that says when an individual does go into HPPD, one, we need to educate on it. We need to say who out there is these facilitators are maybe, in a worst case scenario, will see HPPD. If you do, in that safety plan, what are you doing to help that patient and the time and effort? So most HPPD is time, we say, so more time the better, which some people don't have. But if you have time, that will wear off. There's reversal drugs. We can use two things out of the market right now, and a benzodiazepine. And I'm not saying most of these people will have a benzo available, but if they have to call emergency services, if emergency services EMS shows up, they will be able to administer benzo on site, and that would typically, Ian and group, reverse that HPPD pretty fast, rapidly. There's also a medication that we can use, but that's more in the actual setting of a clinic or emergency room would have that. But that's really, I don't think it's going to happen all the time. I don't see this occurrence, a high occurrence of it, Ian. I just see a low occurrence of it. But with those visual impairments and that dissolution disorder is very serious for that patient because they can lose time, effort, ability to cope with that mechanism. And so I think it needs to be addressed. I just don't know if we need to put it in or where we need to place it as far as like a plan of action on it. That's all I had.
Yeah, I
Thank you.
think we definitely can, not at this time, but I have been thinking about it a lot. And the place I think would be best is in we have jurisdiction over like emergency response preparedness. And so it could be something as simple as like making sure an ambulance is on call, because most ambulances that I know of carry lorazepam with them, which would, if benzodiazepines are the reversal drug, that would help with that. Um, so I think we could definitely, it should be in two places. One should be in education to facilitators so that they know what's going on and just not shocked if they ever see it. Um, and to make sure that, if we are administering this, that there is adequate access to, whether it's an ambulance, whether it's whatever, to ensure that they can get the medications they need. One of the more frustrating parts about federal regulation is benzos, the primary, not reversal, but stabilization agent for psychedelics, typically, or not typically, it is a controlled substance, and we would not have DEA authorization to hold it. But we definitely could have an ambulance nearby that would have lorazepam and could administer that while being on a different site and not directly regulated by the DEA. But I do think that is a really important point. Almost like how, not quite the same, but similar vibe as we didn't provide a lot of education to providers on cannabinoid hyperemesis syndrome, and then providers didn't know how to deal with it. And now in nursing school, we are taught about cannabinoid hyperemesis syndrome to help prevent some of the problems from coming out. Now, just like what you talked about, it's a rare condition and it's not going to affect everyone, but it is definitely helpful to prepare for it. So I do appreciate your input.
Cool. And
All right.
Mitz put in the chat, maybe add to the informed consent protocol.
Perfect. So the informed consent protocol belongs to the dosage administration clinical practice committee, but we are definitely working on preparation sessions at our next meeting. And so we will be able to get those preparations, that informed consent protocol, what we need to screen for. The thing we're trying to get through today is saying which of the tiers do things fall into? Because without that, they're not going to know what we need to screen for in preparation. So do we want to include active eating disorders or malnutrition? Oh, I see James has his hand up. You can disregard my question. What did you have to say?
Ian, one thought just real quick on the HPDB to close it out. There's a great resource in the state with the Poison Control Center. I just wanted to bring that back up again as that's a simple dial the phone number, 1-800-222-2222. And then next thing you know, there's that poison control specialist on the line. And if we can teach them what HPPD is, they might be able to field some of those initial responses. I don't know, it's just a thought because it is a great resource. And they could field something like HPPD. It's not technically anything that we take in excess is considered a poison technically in the body. Anything can be a poison. Water can be a poison. And so HPPD might just fall under something where they might want to research that data and puts us in a data aggregation area as well. Just a thought on using the state that's already set up something there that we might be able to capitalize on, in that education piece to tell facilitators, to tell clinics, to tell, centers or, whatever we're going to call them to say, if you have help, you can also call this number besides calling EMS. But just a thought. Thank you.
Yeah, that's actually great. I really love that idea, especially because the propagation recommendations that we just sent required the poison control number to already be on there. So if we just incorporate that into our, emergency protocols, that would work out really great. Since we've already kind of began to build a structure to utilize that assistance that the state provides, I think that would be a very good thing. I will definitely note that for the dosage. All right. So what did we think about active eating disorders or significant malnutrition? So personally, I would put active eating disorders or significant malnutrition in tier 2, given that, you know, if they are significantly malnourished and that leads to electrolyte abnormalities, that could be exacerbated by psilocybin. I don't think it's a great enough risk where we need to like specialize it out and require all these extra barriers, but something as simple as like a clinical support plan and risk mitigation might be good for them.
Ian, I forgot to ask, would you like me to, in the chat, put the 4 different tiers in the chat so that people can refer back to them?
Yes, please.
All right.
In response to what you just said, Ellen says, I think that's fair. And then James Brown put tier 2.
Okay. All right. Because I think we've covered most of the like main psychiatric bases, you know, bipolar 1, self-injurious and self-harm behavior, impaired cognitive impairment via the informed consent, seizure disorders that are partially controlled we got, delusional, dissociative, personality disorders we've considered, and the main 2 medications that you've considered. So does anyone have any even non-psychiatric conditions that they think we've missed at this point? And then for that bipolar 2, on tier 3, or do you guys want to, until we get enough evidence, just tier 4 it?
All right, James has his hand up. Your mic is enabled.
You know, going back to risk versus, you know, on the facilitator or center and the patient's risk, it definitely sits in 3. I just don't want to exclude these people. The data behind bipolar disorders and research shows a mixed bag. Definitely, they've said, hey, schizophrenia, lithium, maybe even things like clozapine. You know, those things are out the door. But bipolar disorder, it doesn't necessarily mean that the patient should not be able to receive services to me. But I definitely think there needs to be a safety behind it. And so 3 fits that category without excluding them at this time, you know, until we have more data or more research. That's my thought.
Yeah, and I completely agree. I actually, there can be overlapping conditions. I think we're aware. So just because, you know, someone has bipolar 2 disorder, that might not be their primary concern. It could be the nightmares associated with PTSD. It could be the anxiety. So I definitely agree with you, James and Ellen, who said I would agree with tier 3 on bipolar 2 in the chat. So I will go ahead and enter that. Uh,
Alright, it looks like Ellen has her hand raised. Ellen, your mic is enabled.
Oh, sorry if I missed this because I don't think I was paying attention to the tiers either, or I was thinking that 4 was a little different. So when we talk about dissociative personality and dissociative disorders, I mean, I thought there was a little conversation about that as far as from a personality disorder. Yes, I understand that's ingrained, and if we're putting that as a tier 4, but dissociative identity disorder and dissociative disorders are not considered personality disorders. And I don't know that that's where I was saying with the history, or if someone had maybe that put down somewhere along with a PTSD or something else potentially, that I didn't want to completely exclude some of those people. If they had like episodes of derealization or depersonalization, that's not uncommon that it might be a PTSD that they got that diagnosis on top of it, and it's actually coming from trauma. So I was a little concerned about having that completely as a tier 4. Now, something like a personality disorder, that's a little different. But to me, not the dissociative disorder. That's not considered a personality disorder. So I would still argue that that should be considered under tier 3, especially with the history of things.
Perfect. All right. Thank you. Um, so are we in agreement that dissociative disorders should be in tier 3, or should we put them in tier 4? Anne?
Sure. I mean, I think if there are medical providers out there that feel comfortable with that kind of a risk profile, I think the overlap of symptoms between dissociative disorders and PTSD is a reason to probably include them. But yeah, I mean, I think it's really, I think that's going to be the big issue is, are providers going to be comfortable working with that population? Are they going to be able to have appropriate supportive resources? And if that's there, I think tier 3 makes sense. Yeah.
I agree. I think tier 3 looks like it's more exclusionary, but I think it allows us to incorporate or to allow more patients than otherwise would have been allowed, because I feel a doctor, we'll say a generalist doctor, is probably not going to feel as comfortable treating someone with complex psychiatric diagnoses. But if you got a psychiatrist on board, then they would work together to create, that risk mitigation, um, and all the tier 2 documentation, but they would also, consult them and say, hey, is this right? Does this patient fit for this? And it defers to someone whose only specialty is psychiatry. And that would, if I were in that position and I was the prescribing psilocybin practitioner, I would feel much more confident if I got a complex case and someone reviewed it with me than if I was doing it alone. So I would agree with dissociative disorders in tier 3. Uh, then I know this is not a psychiatric condition, but I just realized I also omitted from the draft cardiovascular accident, or TIAs. Where would you guys like to put those?
All right, James Brown has his hand up. James, your mic is enabled.
in group, if that patient has an active TIA or has had a recent TIA, that's almost a contraindication for use at that point in time. So I didn't know if it falls underneath, kind of like with active angina or other things of that cardiovascular. It kind of, to me, fits right there with, uncontrolled hypertension and uncontrolled things. But TIA is pretty serious.
I guess my question is, how long would someone have to go without a CVA or a TIA to be fine? Is there any amount of time that you think we feel would make it safe? Or is
I
it
think
one
there
of
could be
those?
there'd
Sorry, go
definitely
on.
be reassessment. I think neurologically they'd have to be cleared by, definitely their provider would have to clear them. Like they'd almost need like even for the facilitator and all them, they'd have to almost have like a pre-clear, because it could be forever. Just depends on, was there a shift or no shift? What's going on with the actual, disease state itself? It could limit them or prevent them completely.
Okay. I would be perfectly okay with putting it in tier 4 conditions that if they, because in that definition, right, it provides that reassessment may occur only for medical conditions that have demonstrably resolved and for which documentation supports sustained clinical stability. So I think that would fit in perfectly with the other ones in that those other cardiovascular conditions. All right. So here is what we have been working on. I will give anyone any time to consider any conditions that I have not. And we can go ahead and vote on these ones. Jorge, would you mind bringing up the document, the clinical support considerations? You have it up. That was my bad. So just to recap what we've been discussing, TIAs and CVAs, tier 4, active eating disorders or significant malnutrition, tier 2, bipolar 2 disorder, tier 3, history of delusional disorders, tier 3, dissociative disorders, tier 3. All right, any comments before we move to a vote? All right, with no comments, we will go ahead and vote on this. If you are in approval of the clinical support considerations that and their placements, please raise your hand at this time.
Okay, I did see 4 hands.
Perfect. And then if you are against this document, please raise your hand at this time. Or sorry, lower your hands first. And then if you are against this document, please raise your hand at this time. And then the clinical support considerations are considered. All right. Well, that is what I had to go over today. So let's see if I have. All right. Well, I don't have anything else prepared for today. Does anyone else have any comments, things we should discuss at the next meeting, or things like that?
I just want to remind folks, on the screen, we had how to submit written public comment. The document, if you submit a document no more than three pages in length, 10-point font, please include your full legal name and any organizational affiliations, and please send those to the medical.psilocybin@doh.nm.gov email by 5 o'clock the next day, 5 p.m. the next day.
Alrighty. So now is the most fun part of the meeting. We get to decide our next meeting date. So let's see here. All right, and then this one should have all of the, yeah, okay, cool. All right, so looks like the dosage committee will meet on the 16th. They will be working on preparation session stuff. Would everyone be free for the 17th at 9? Or do you all have a date that works better?
The 17th is going to be a Tuesday.
And that looks good for us so far as well.
Anyone in the chat not able to make it that day?
I saw a couple of thumbs up go.
Cool. Well, then we will do the 17th at 9 a.m.
Great.
I will call this meeting adjourned. Thank you guys so much for coming. I appreciate all of your input, all of the time that you guys put in today, and all of the debate. I really appreciate all of you guys just taking the time to be here. It means more to me than you guys know. And I'm really glad that we're going to make a great program together. So again, thank you, and have a great rest of your week.
Thank you, everyone. Thanks for being here.